today's lecture, which is about complications related to full arch prosthesis. So this part is going to be broken into two sections. One is on fixed full arch restorations, which is the first part, and then we'll come back and talk about removable prosthetics complications. So by far the most common issue with full arch restorations is veneer fracture or resin veneer fracture, okay? And I'm going to lump that together with denture tooth wear, which happens around 15% of the time. With resin veneer fracture, that's 28% reported in the literature. And that's very, very common, right? And it's a problem that is easily fixable in a lot of situations, but it is a significant problem because when patients are paying a large sum of money to get some of this treatment done for full arch, to do full arch restorations, if something breaks, it's quite traumatic and it kind of puts a lot of strain in the dentist-patient relationship. So we really need to sort of look at how we can address this and really further minimize this from happening. So why does this happen is conventionally for these all-on-4, all-on-X type full arch restorations, the most conventional treatment is acrylic veneered over a titanium bar. Okay, so it's denture teeth attached to processed acrylic, which is the pink part, and it wraps around the titanium frame. Okay, and that's kind of the most traditional way of doing these type of restorations. As you can imagine, when this is done, there's some disadvantages, right? The individual denture teeth are not monolithic, right? They are actually bonded to the processed acrylic. When this is processed, the acrylic shrinks. There's a lot of internal stresses. There's a lot of movement of the teeth. That's why when you do dentures, sometimes when you put it back, when you actually deliver the denture, there's a lot of adjustment that needs to be done that's kind of inconsistent from when you kind of tried in the teeth. This is because when the denture is processed, the acrylic shrinks and there's quite a bit of tooth movement. So if we look at the studies on this, right, this article shows that reported that there's basically a 66% chance of some kind of breakage in the veneering material, in this case acrylic. It's the 66% chance of something happening over 10 years. The 5-year complication rate with things breaking is actually 33%. So with the 66% risk of fracture or veneer tooth fracture at 10 years, it's actually substantial, right? So it's not a matter of if things are going to break, it's a matter of when it's going to break, right? Even if it lasts 10 years, by 11, 12, 13 years, there's going to be some kind of breakage. And even if things don't break, there is definitely going to be a denture tooth wear, right? There's going to be wear and tear. So generally from somewhere between 7 to 15 years, likely the veneering material for the prosthesis needs to be renewed, okay? Even if the implant is holding up, even if the titanium frame is okay. So it's a problem no matter what, and this needs to be communicated with the patient at the beginning of treatment. So is there a way to utilize the same materials but designing it in a better way? And this is the way that we do it now at our practice, by using milling technology, CAD/CAM technology, and monolithic materials. Okay, so we still use titanium to do the bar. We still use acrylic or PMMA for the teeth, but we can actually mill it from a monolithic puck. The steps to doing this method is actually the same. We still set teeth, right? We still do a try-in. And the only difference is that instead of using denture teeth and putting into wax and then melting it and then having the lab processing the acrylic like a denture, we're actually then scanning the wax setup and milling a monolithic superstructure in PMMA from a puck form. So why is this better? Is because if it's milled out as monolithic, right, is not individual denture teeth attaching to processed acrylic. When it's monolithic, there's no shrinkage. The shrinkage has already happened when the puck was made. Because there's less shrinkage and it's from a puck, it's made in a controlled setting by the manufacturer, generally these materials are less porous, right? So if it's less porous, less shrinkage, it's going to be stronger. And the major benefit of this is down the road, if the patient does break something, break a tooth or there's wear and tear, this file is essentially safe, right? All we have to do is now call the lab to re-mill out this superstructure, have it ready, get the patient to come in, we take off the prosthesis, we give it to the lab, they can just remove the old acrylic, cement on the new acrylic, and it's done in essentially a day. And we're able to sort of maintain the vertical dimension and really kind of replicate what was done years ago, okay? Whereas if we're doing the traditional method with denture teeth, right? A lot of times when you have to sort of redo the teeth part, you're redoing a lot of the steps, right? You still have to do, reestablish the vertical dimension, reposition teeth, do a try-in, and then send it back out to have it processed. So with CAD/CAM technology and scanning and milling, there is a way to reduce the chance of things breaking and actually minimize the time necessary to fix these prostheses when it does wear away or break. Are there disadvantages of this? The major disadvantage is really a learning curve for the laboratory. I see no real significant barriers to this because most labs now are able to do milling. I'm sure they can scan. It's really just a change in the mentality and in the process, right? One challenge that needs to be dealt with is sort of the dealing with the pink aspect of the prosthesis. If this is milled out in one piece PMMA, the pink gingival aspect needs to be bonded on after using pink composite. So there's some technique that needs to be learned. And it used to be less aesthetic in the sense that most of the pucks were monochromatic back in the day, but nowadays there are pucks, PMMA pucks that have a gradient of shading. So really aesthetics is pretty much very similar to the traditional method of using denture teeth. So a milled PMMA superstructure is milled out, and that gets cemented onto the titanium frame utilizing just more cold cure acrylic. So it's not really bonded, it's more just mechanically locking onto the bar, and then pink composite is layered on afterwards. If we look at a case like this patient went to get full molar rehab done, and literally within a few months his lower left molar fractured off. If we look at this case from an occlusal view, we can see pretty much three most common errors that has occurred here, right? One is the lack of prosthetic space. Number two is probably improper bar design, right? If you look at the titanium bar in the position of it, it's really not supporting the functional areas of the teeth, right? And for example, in the lower, the functional cuffs on the buccal cuffs, the bar is very, very lingual. And so when the patient bites, essentially there's a buccal cantilever, and it doesn't take much force for the acrylic to kind of snap off the bar. And sometimes it's a laboratory error, and we'll go over some of the most common causes of this. If we look at the more of a side view, we can see here there's extremely very, very little space covering the occlusal part of the bar, the lingual part of the bar, and on the lingual aspect of the bar. There's less than a millimeter of acrylic wrap around the bar. So when you're designing a wraparound bar design prosthesis, you need to have enough space to actually allow the acrylic to actually wrap around the bar. And so a very, very common question I get is, how much space do you need to do these type of restorations? The answer is, it depends on a lot of factors, but in general, 15 to 21 millimeters of space from the platform of the implant to the incisal edge, right? Why do we need this much? If we sort of break it down into sort of the measurements, right, from the bottom up, if it's an actually wraparound bar design, okay, starting from the platform up, the soft tissue for most people is going to be somewhere between 1.5 millimeters to 3.5 millimeters, right? That's going to be the vertical distance that's allowing the tissue to exist, and also allows for your abutment to exist, right? So that's potentially 3.5 millimeters of space gone right there, okay, from the platform, above the platform level. Then, if it's a lower prosthesis, oftentimes it is highly recommended to have some hygiene space, right? So another 1.5 millimeters of space from the soft tissue to the integular surface of your prosthesis. If it's a wraparound bar design, right, should be at least 1.5 millimeters of acrylic below the bar, then a 3 millimeter titanium bar, which is the minimum thickness that most people will mill for you. And then there should be at least 1.5 millimeters of acrylic on top. that then connects to the denture teeth. And then a denture tooth, depending on which tooth it is, should be somewhere between 6 to 10 millimeters in heights, right? Depends on how much, which tooth it is. And so if you don't have enough space, the first thing the lab's going to do is start trimming away the denture teeth. So now your denture teeth becomes thinner and more easily, it can break more easily. If they don't have enough space even after that, they start removing hygiene space, having less acrylic between the bar and the teeth, then higher chance of the teeth popping off. And if there's less acrylic underneath the bar, then there's a higher chance of the whole segment just breaking off the bar. Okay, so without space, everything is thinner. If everything is thinner, things are gonna break more easily. So that's why there's enough space. The prosthetic space is very, very important. Another factor that affects how much space you need is smile line. So regardless of how much space you have, if the person has a very, very high smile line, right, you need to put the implants higher up. Basically, you need more space because the transition zone between the soft tissue and the prosthesis needs to be above the lip line. So if your high smile line, the implant prosthesis has to start higher up, and it could be more than 21 millimeters, right? If you need more lip support, and the patient has a lot of buccal resorption when wearing a prosthesis, a denture for a long time, there's a lot of horizontal resorption and they need a lot of lip support, the implant needs to go higher up so that there's enough vertical distance for the prosthesis to sort of kind of emerge out so you don't get any ridge laps. In general, larger the horizontal distance between the incisal edge and the implant position, you want the implants higher up. So in class 2 patients where the teeth needs to go way far out and the implants are way far back, the implants have to go higher because you need some vertical distance for the platform, for the prosthesis to go from the implant and to flare out to the incisal edge. And this picture will simulate that. It will kind of show you if the edge is for anterior, the implants are way palatal, you need more vertical distance for proper emergence. So there's no 90 degrees ledge like in this case, right? In this case, there's a huge horizontal difference in position. If the implants are not high enough, you get this 90 degrees jetting out of the prosthesis, which is harder to clean because it's more of like a ledge. So sometimes if the bone is really far palatal and we anticipate the incisal edge to be way anterior, sometimes the solution is to not put anterior implants so that the whole prosthesis in the anterior zone is more like a pontic, right? They just floss underneath it and that's it. So even if the whole prosthesis is in front of the ridge, right? It's not really ridge lapping, it's sort of like an ovate pontic in front of the ridge. So it's more hygienic. And so sometimes no anterior implants is indicated. So if we look at that case we talked about earlier, if we look at how much occlusal space there is and how thick the acrylic is, it's less than 1 millimeter on the occlusal surface, on the intagular surface, and on the lingual surface. So it doesn't take much for this tooth to kind of fracture off the bar. The next is bar design. Okay, this is a very, very common issue that I see that causes a lot of these problems, right? The reason is when the implants are placed, oftentimes people have resorbed ridges, and as the ridge resorbs, it resorbs towards the lingual aspect, right? And when the teeth are set, the teeth needs to come back out buccal, okay? So oftentimes the implants are placed lingual to where the teeth needs to go. And a lot of times clinicians, send the wax up out to the lab. The lab may then offload the scanning and design of the bar to another milling center. And these milling centers may just design a bar and just kind of connect the dots, right? They're very typical. They draw like a line, connect the dots, and make a round bar in a curved format. As long as it's sort of within the structure, like within the within the outlines of the wax setup. The problem is, even though this bar is technically within the prosthesis, it's way too lingual and is not really supporting the functional aspects of the prosthesis, right? And so in a case like this, the bar actually should come out buccal. okay, to where the implants are, so I can actually support the acrylic, so things don't kind of shear off or kind of just fracture off. So really, you really should be checking the bar design, because once the bar is designed and milled out and things start breaking, it's sort of a very, very, very hard thing to fix, because you basically have to redo the bar, which is basically the whole prosthesis. So we keep going back to this one case. We have limited space, right? The patient usually have at this point limited funds because they already sort of spent their money doing the first set. The question is, can we now get more space by increasing the vertical dimension, right? If we open the bite, we get more space. Sometimes people can't tolerate it, which is the case here. The patient can't tolerate more increase in the vertical dimension, so we can't get more space. Can we consider doing a new implant, right? One solution is to take out this implant at the 3/6 site and put an implant deeper with some more ridge reduction. As you can imagine, most patients are not going to want that. They already did the surgery, they're not going to go and get another implant, right? So can we do a zirconia prosthesis? Well, in this case, a zirconia prosthesis is not even going to solve that, because even if you do a zirconia prosthesis, you need tie bases. And so to connect the prosthesis to the implants. And the tie base has a certain height. If you put a tie base in here, again, even if you do zirconia, there's going to be less than 1 millimeter of zirconia wrapped around the tie base. Even the zirconia can probably fracture. So in this case, can we do a titanium tooth? Some systems can do that, right? Some milling centers can actually mill out a bar, but and mill out a tooth structure, like a kind of a tooth form, as part of the bar, right? So in this case, it could be done where the 3/6 is a titanium tooth, and the bar connects everything else. This particular milling center and this implant brand, that can't be done. Sometimes you can actually do a bar where it's sort of like tooth preps, and you can actually do individual crowns or layer porcelain directly onto the metal bar. You still need space for that, because even if you do individual crowns, you need retention form, right? So that technically won't work. You could mill this in a cobalt chrome bar and layer porcelain directly on it. Again, this system and this milling center could not do that. So what do we end up doing for this particular case to kind of solve some of these issues? We do a setup, right? We try to open the bite as much as we can. Looks okay from a buccal view here. But if we look on the lingual view, we see this is the buccal ridge lap, right? Because if you look at the platform, it's actually much higher up. And some people at this point will suggest, well, can we change the abutment and make it shorter and go direct to implant platform, right? Which you can gain maybe 3.5 millimeters if we can actually screw it directly onto the implant without an abutment. But in this case, the implant is an angled implant. And so if you don't use a multi-unit abutment, there's a real challenge getting an impression, number one, and number two, screwing things in. Like every time your screwdriver is going to come way distal. So we decided to kind of leave the multi-unit abutment on. So this is a sort of a ridge lap. There's actually not much space here. And so 3/6 is a major problem. So in this case, we still did the milled PMMA superstructure that we normally do. That gets cemented on top of a titanium bar. And how we design it is more of like a T, upside down T cross section, where the entire intaglio is supported by titanium, so the acrylic won't really shear off. And in the middle of the bar is sort of like a fin with a 5-degree taper for retention form. And generally there's some retention elements, like some holes where the cement or the cold cure acrylic can actually go in between the holes and kind of lock everything in place. And that gets cemented on top of the bar with more acrylic. Then the 3/6 is still a challenge because there's not enough space. So in this case, we decide to actually do a single zirconia crown that gets put into that bar. And so once it's done, it's kind of like that. It's kind of a little bit of a ridge lap, but the patient is able to keep it clean. And that's kind of how we sort of fix up this case. On the top here, we did monolithic zirconia. So there's no layering. Patient has a low smile line and aesthetically looks okay for him. So now for this case, I'll tell you what has happened, right? So long story short is at 5 years, everything is holding out well, except that he's now wearing down the acrylic, but the 3/6 zirconia crown is not wearing down, right? And therefore we have to constantly adjust his bite or add acrylic to his other teeth so that he's not just kind of constantly biting on heavy on the 3/6 crown. Okay, so it takes a lot of management, frequent recall checks. So prosthetic space is very, very important in order to reduce the chance of things breaking. And if there's not a prosthetic space, it's a sort of a lifetime of issues for the patient. And there's really not much prosthetic that you can do to really fix the problem. So the second most common complication is a screw access filling coming out. Very, very easy to fix, and it's not a very difficult problem to fix, but it happens 25% of the time apparently. And really that's just your screw hole fillings coming out. So what I usually do that will reduce this from happening is I like to pack a Teflon tape into screw holes using a continuous tape. So we pack it in. We then, once we reach around 2 millimeters below the occlusal surface, we cut it up. So the entire Teflon tape is one piece. And then we dry it, we pack on composite, we shape it, we have the patient bite down, we smooth it, we cure it, and then we polish it up. So as long as there's 2 millimeters of acrylic, 2 millimeters of composite into the hole or deeper, then usually things won't really pop off. So that's an easy complication to address and to prevent. The next one is porcelain chipping. Okay, so the first one was kind of resin fractures. Now we're talking about porcelain or ceramic chipping or fracture. It's harder to fix because ceramic is harder to repair. Usually that needs to go back to the lab. So before we go more in depth, we want to just sort of explain the definitions of what we're talking about here, right? So a lot of people will talk about all ceramic. We throw around terms like zirconia or porcelain or ceramic. Ceramic is the overlying term that describes everything that's kind of like the white stuff, right? The inorganic stuff that we use in dentistry. So zirconia, Emax, which is lithium disilicate, or porcelain, are all types of ceramics. Porcelain is the powdery stuff that ceramics use to layer on top of PFM crowns for feldspathic veneers, layering on top of Emax, or layering on top of zirconia. So porcelain is really the quartz, the feldspar, and the kaolin mixture that is used constantly, very, very, very frequently in dentistry. So again, ceramics, there's the most common, we use it all the time, is lithium disilicate. The most popular brand is by Avoclar, they call it Emax. GC makes the same stuff, similar stuff, they call it Lisi. We use it constantly. I'm sure everyone here will use that to do single crowns or posterior crowns or veneers. Feldspathic porcelain, again, it's the nice transparent stuff, translucent stuff that's very, very lifelike, that can be done for a veneer, or can be used to be layered on top of zirconia or Emax or PFMs, right? Or zirconia, everything, okay? And then zirconia is, I'm sure most people here will know what zirconia is, but it's a ceramic and it's very, very high strength, but generally they're more opaque. So just because ceramic exists doesn't mean that everything needs to be ceramic. Generally, when a patient needs to do an upper and lower fixed prosthesis on implants, generally my first choice is still upper in ceramic and lower in acrylic and titanium. And the reason is there's controlled wear, okay? We tell the patient, look, at some point in time, things are going to wear down or break. If it doesn't happen at 5 years, if it doesn't happen at 10 years, it's gonna happen at 15 or 20 years, right? If upper and lower prostheses are all ceramic, we don't know which one's gonna break, we don't know which one's gonna wear down. Maybe the ceramic doesn't break, the screws can break, the implants can break. So if the upper is ceramic and lower is an acrylic, and we mill the lower in acrylic, we know that down the road, if things do break, which way they will at some point, it's going to be limited to the lower arch, which we can easily call up the lab and just remill out the prosthesis and basically recreate what was done years ago with minimal time, cost, and appointments. Okay, so when it's upper and lower, full arch implant cases, I like to do ceramic on top with like zirconia with or without layered porcelain, and then the lower is a milled acrylic on a titanium frame with pink composite. So aesthetically, there's not a huge difference between milling the acrylic versus denture teeth. There's a learning curve. In our first few cases, denture teeth looks a little better, but now between me and the lab, generally the milled acrylic looks just as good as denture teeth, and we can definitely match it pretty good with ceramic on top. So if we're using ceramic, such as zirconia, for these full arch restorations, we have many options as to how to actually design it to receive the veneering porcelain. And so the strongest, which is on the left side, is monolithic zirconia, right? Like any coloring is by staining, right? Just pre-staining the zirconia or surface staining. When there's no veneering porcelain, that's the strongest it's ever going to be. So it's high strength, but it's high opacity. On the far right, we can create the most translucencies by having a zirconia substructure, like an abutment basically, with layered porcelain on the facial surface, the incisal edge, and maybe even the lingual. So if the entire incisal edge is porcelain, you can create a more translucent incisal edge, which in some cases is desirable, could be more aesthetic, if the patient wants that, but the highest chance of chipping, because porcelain is the weak stuff. Somewhere in between is you get the best of both worlds, where the incisal edge is kind of split 50-50, where half of it is porcelain and half of it is zirconia. You get some strength, you get a little bit better translucencies, but it's in the middle. So depending upon what your patient wants in terms of aesthetics and the functional aspect of this, do they grind? You look at their previous teeth, was it a wear case? Or was it a periodontal disease case, right? If they're a wear case, we probably shouldn't be doing something more on the far right because there's a high chance of chipping, right? If, you should probably then do something more towards the left. If their previous teeth didn't have that much wear and tear, it was more like a caries case or a perio case, you're more likely to get away with a design that's towards the right side. And I'll give you some examples for each one. So this is like a design which is the most complex, where the zirconia substructure is designed like tooth preps, and then individual crowns are cemented onto the bar. Okay, and these crowns could be PFZ crowns, could be PFM crowns, could be lithium disilicate crowns. It doesn't matter what type of crowns, but these are then cemented onto the bar either by you or by the lab. What is the major benefit for this type of design? The major benefit, really only two. One is for situations where the screw holes are coming out facial to the prosthesis. So these are usually done as a way to sort of bail out the situation, like the really, really bad implant angulation, where even with abutments, the screw holes are coming out the facial. If in these cases, then if the crown is cemented on, you hide all the screws. The other potential benefit is if things chip or break, you just have to replace one crown, right? You cut off that one crown, you take an impression, and you're basically remake one crown. But it's complex and it's usually higher lab fee. A second type is where things can be the most translucent, right? And keeping it one piece is to designing the zirconia kind of again like tooth preps, right? But then having layered porcelain directly going onto the zirconia. Very good translucencies can be achieved by this, but risky in terms of chipping. right? Because there's a lot of porcelain here, kind of like a veneer. You're basically veneering all your teeth. If you're doing it like this, obviously in the molar side, in the premolar sides, you don't have to have that much porcelain, right? The molars can be more so in zirconia. Probably should do this in the front 4 to 8 teeth only. One step to the left is to actually have zirconia porcelain on the facial and just the incisal, but the linguals are all in zirconia. It's obviously a little stronger. A little bit better is actually having zirconia all the way to the edge. So there's sort of a lip that protects the edge, but the vast majority of the facial surface is layered porcelain. It's a little bit less prone to chipping. One step to the left is now actually having the entire edge in zirconia, and the porcelain is purely on the facial. And how are these two the difference? One is just the amount of layered porcelain, right? So you can have a ceramic layer of 1 millimeter or 1.5 millimeters of porcelain on the facial, down to even just 0.3 millimeters of facial porcelain. And some ceramics can make things look very, very natural, utilizing only 0.3 millimeters of facial porcelain, and everything else is just purely zirconia. And the last one is pure zirconia, no porcelain. Everything is zirconia, and everything is just colored on and painted on, okay, in terms of color. There's sort of a option here, and sometimes we do it in pure zirconia, but for the pink aspect, do some pink porcelain, because pink porcelain always looks better than kind of staining pink gingiva. Okay, just purely staining without texture doesn't look as realistic as pink porcelain. And then there's some of these more advanced situations where you're using hybrids, right? Where it's zirconia with or without layered porcelain, cemented on top of a titanium frame underneath. And this is sort of like what I call like bulletproof restorations, where it's not going to get any better than this, right? There's a zirconia frame for strength. The chance of zirconia fracturing is much lower. The intaglio is in polished titanium, which is probably the best, most hygienic thing you can do. But you also get zirconia in terms of aesthetics. And in some extreme cases like this, where in a way is a rescue case where the implants are really far lingual because of ridge resorption, we're asked if this is pure zirconia, we're asking the zirconia kind of do a lot. They sort of have to travel a long way. So we design a titanium frame underneath. So we put these all and line up together from the most opaque on the left side to individual crowns on a titanium bar on the right side. We see not a substantial increase in aesthetics, right? I would say definitely monolithic zirconia on the left side is definitely going to be more opaque compared to everything else. But I would say a good happy medium is something in between, right? And whether you go towards left or go towards right is based upon aesthetic demand and functional requirements. Okay. We look at, is the patient a bruxer, right? How did they break down their teeth previously? Do you look at their jaw, their face shape? Are they a square jaw, like, low FMA? Big masseters probably should not layer everything so much in porcelain, right? You look at their previous teeth and restorations. That will give you a good idea as to how that patient functions, how they break things down. The position in the mouth doesn't mean that you have to do monolithic everywhere or layered porcelain everywhere, right? Sometimes we do monolithic in the molars, and then as you go forward, more and more porcelain is utilized for better aesthetics in the front. The span of restorations, is it a long span bridge here where there's a chance of the zirconia cracking? Maybe you should do metal, right, or monolithic. And then the position of the implants, right? If the implants are close together, sometimes there's a lot of screw holes side by side. There's a higher chance of things cracking where there's a lot of implants. So sometimes more implants is not necessarily better.